sort of press our foot down and pedal a bit more on this?
I can say this to you, Chair, that we would like some of these things to happen tomorrow. But clearly, I think we are realistic about the dads, etc., to turn things around. And I think we are giving 1st of January as a very safe option. We would like some of these things to happen now. And we would like to see the more we do that now, then we will be reducing the number of amount of resources we spend in nursing home, care beds, care beds, etc. And we will be spending more and more on care packages in the community, etc. We want faster response from dads, etc. We want to do that, but we understand that some of these things are historical, traditional, and it will take some time to make that.
So can I ask you, what are the kind of barriers then to doing more quickly on reopening?
I won't speak for a lot. I always get accused of speaking for too long, so I'll just try to keep it brief. The Wirral has what's called an intermediate care service. And the intermediate care service in the Wirral is about beds in care homes. Most places who have an intermediate care service have a service that supports people in their own homes, supported by a few beds when required. We've got to turn that model around to improve it. We've got to go back to basics really in terms of the way the National Service Framework for Older People defines intermediate care, which is you start at somebody's own home and you build services around them to help them feel in control and supported and get back on their feet. We have a reablement service here which is with independent sector providers, again in an unusual position. Most local authorities have got rid of their long-term support through their in-house home care service, but have managed with the NHS partners to design a reablement service which actually is a publicly provided service that supports people in their own homes as part of the wider intermediate care response. We've got to redesign all of that. We've got to find the resources to do it. I think behind your question is the natural place to go for the resources to help with that is the reablement grant, because essentially that's what its terms of reference are. But, you know, quite clearly, as Abby's pointed out, because we have a different kind of service here, we've got a range of responses which has tied up resources in a way which we don't want to tie up. And a lot of it is about short-term placements because we haven't got that responsive service for people in their own homes. Sarah herself and others are working very hard to try and put together that alternative model. We intend to have that so people can see what it's going to look like in August. And I agree with you. We need to put the pedal down in August and try and get that moving as quickly as possible.
That's reassuring.
I think one of the issues that makes it slightly longer to achieve is that current services supporting the hospital, supporting reduced length of stay in the hospital, and it's very difficult to just stop those services at a full stop and reinvest that within, in something else. If you don't know that something else is going to work for a start, and you know what's currently happening is having an impact on hospital length of stay. So we can't just stop the services that we're investing in now. We have to have a transition between what we're doing now and what we want to do in the future to stop there being a big impact on the hospital. And I think that's the key reason why we're not doing it right now. There has to be a transition in order to safely manage it and stop there from being a big impact on the hospital.
Yes.
Into the service that was tendered in early 2011, is that the one that's provided by the independent?
There are three providers who responded to that tender to provide reablement services, and to be perfectly honest, with the exception of one of them, they really haven't exposed the market in terms of giving us what we want.
So it's whether the performance diagnosis and that to do with it.
Okay, any other points anybody wants to raise? I mean, I think we're being asked to sort of note and support these proposals, which I think is fair enough, but I think it's something that we need to monitor, as a health and wellbeing group quite closely, because I think this is really a key priority for us. Okay. Thanks to...
We agreed to have the milestones and the dashboard back on this development.
Sarah. Thank you very much. Okay, let's move swiftly on now to my favourite topic, the spending review 2013, item 6. This is Claire.
Just very briefly, Chair, this is what people have been referring to in the meeting, which is the letter that was received to the chairs of health and wellbeing boards and the directors of adult services, which relates to the fact that there's 3.8 billion nationally has been agreed between the Department of Communities and Local Government and Department of Health, specifically for pooling funding to encourage faster integration across health and social care. Talks about the fact that they have successfully fully funding social care reform, and that the NHS budget is protected in real term, will be a real term increase from 2015 and 16. There's a big emphasis on the fact that this 3.8 million is going to encourage greater integration and working more effectively together, encouraging early intervention, delivering care that's focused on individual needs, and also it's focused on the support for carers as well, which obviously is a critical part of the whole system approach. There is a reference to how this pool money is going to be accessed, and I think that's still work in progress in terms of understanding in detail how that's going to work. But clearly it's very much focused on this early intervention and keeping people out of hospital as quickly as we can. It references the Pioneer pilot, which is another item on this agenda. Closing date was the end of the month, and we have submitted that. There's a decision for the board as well today in terms of understanding the details of that pilot. So those are the key headlines, but I don't know if you have any questions in the room that's to raise. I think it's work in progress.
So I'm still not clear from the letter from the DCLG and the Department of Health exactly how this money is going to be accessed. It just says very vaguely on page 2, paragraph 2, 3.8 billion includes additional 2 billion from the NHS. Access to the full budgets will be conditional on agreeing plans with local health and wellbeing boards to protect access and drive integration of services. So where are those plans? When are they going to be produced? Who's going to be producing them? What needs to go in them? What's the time scale? I just need, I don't know if anybody's got more intelligence than this letter, because it seems a bit vague to me. Can anyone help?
One thing I can help you with, I can make it remind you of our structure. So since 2015 that it's supposed to happen. So I think we wait for more guidance.
So there'll be more guidance, will there?
I think we are going to
Sophia.
Yeah, I accept there will be indeed more guidance. I suppose really putting it on the agenda today is about signalling that there's a bit of work for us to do to prepare for this, because what we don't want to be doing is having to make some decisions very close to when the actual change additional funding comes into place. And I think linked to the comments that Andrew's making earlier about needing to understand what those funds are, whether they are going to be fit for purpose for the future, and how that might change our decisions that we're making currently as well, because it's one thing, something somewhere in the future, but all too quickly it's suddenly there. And I think also you make a plan today and you haven't made some kind of adjustments of thinking, well, we might get some other ways of doing that. So I think it does make more pertinent the conversation we've just had around the system we want to introduce, really being robust and Sue was saying, sustainable for that longer term, and that we can then tailor this investment to help us to deliver that, but not having to then come up with a new plan. So the earlier we get into those conversations, the better we are.
Going back to the previous conversation, Mark talked about the Section 256 agreement was the start of the journey, and the journey we're starting on now, and the work that we do now, stands in really good stead for when, whatever this looks like, when it comes in. We've already started on that journey, and our plans will be well developed to actually take maximum advantage of the opportunity that this will give us.
Okay, I've got Phil and then...
I think it's timing. I think the 256 agreement that we heard about is an important first step, because for me, if you look at what this money for Wilson seems to be, we're probably looking in the region of about £10 million from our baseline NHS, we do down to a patient level, so numbers of procedures in hospitals, numbers of admissions, numbers of community services that we purchase on behalf of rural patients and public. And so I think we have got quite a lot of development to do over the course of the next year or so in preparation for this, so that we have as much data about this broader spend going forward as what we currently have about our NHS spend. There isn't £10 million in our budget that we can't instead spend money on. This is real money that we're spending today for health, and therefore it's absolutely critical that how we spend this in the future is in areas where we can reasonably work together, because there isn't slack in the budget. It really does have to work incredibly hard in order for us to be able to both balance our budgets and also provide the services that we want for patients.
I was just going to pick up Claire's comments really, which are around previous items. It is a step along the journey, and I think all the rooms are moving towards a more integrated service for patients closer to home, more in their own home. That's where we're moving to, and that's the Wirral Lane. But to get there, I think there's just a bit of that. Integration means different things to different people. Different things we go for different health services, as it will for health and social care. So we just need to be clear about where this journey is going to take us, because to make that service work in the patient's own home, we will need different services in a different configuration. And that may well mean a different type of hospital services and a different type of, in terms of health centres and in terms of community services. The first step will help us get into pooling the budgets is only a tool that helps us. It might be worth having a discussion around what integration actually looks like for us. So I think it would be useful just to get that captured in some place. And maybe that's through this process that we do in terms of milestones and the budget.
Okay, thanks. Phil?
I'll put something in layman's language and then I can get shut down. Let's imagine a patient in the hospital needs to be discharged, was pretty well enough to be discharged, so can't go home unless there's a care package in place and people are lined up, various agencies are lined up, information's transmitted along the line and it falls in place at the right time for them to really go home and check the relatives and all the rest of it. That's my theoretical understanding of what happens, but I can put it wrong. In this letter it talks about the need for people to explain their problems once, or try to refine the system. So whoever sees them at the bedside, layman's term again, collects information, says, well, I can send that by wonderful means to whoever I'm going to try and get in place to do this. What is to change in order to bring that about?
Okay, Mike?
Yeah, well, that's exactly some of the work that we're very engaged in at the moment, and it's a single assessment. We've now got an agreed position with the NHS for an initial single assessment, which will be passportable information that will stay with us right through their journey. That means that they haven't totally sorted everything yet, but that means that they won't have to keep giving that initial information, which has led people to think that they need services again and again and again. So we're trying to reduce the number of handoffs, we're trying to reduce the number of times people feel they're being reassessed, and making sure those assessments pass forward through the system. We're well on with that. We're moving on to the long-term conditions work that I'll talk a bit more about, but that's a key part of it.
Okay, Simon?
What I'd just add to that is I think that the important bit for me in all this is getting that whole system, the model of care right. That's what we're talking about. These are really important pockets of money which will help us do that. They're not new money. It's really important that we track it because the system says we have to track and justify that. But we're actually having a conversation about the health spend and the adult and children's social care spend, using it as wisely and as cost effectively as possible. That right model that says, because we have to, actually goes back to Puffle, we have to get people getting involved and taking responsibility for their own health where possible and using them as an asset. We have to get the system working as smoothly as possible. And it has to be one that we get it in a way that it is more cost effective to ask people in their own homes wherever possible, with quick in and out of hospital where that is required, because that's the only way we'll make all of this add up. And tracking these bits of money and using them wisely is part of that. It's got to be a whole thing. And
Can I just be clear though, have we, just picking up your point, have we got a clear picture, vision of what an integrated health and social care system will look like, so that we know what we're working towards?
For Wirral.
For Wirral, yeah.
I think we'll all,
Have we got that?
all have the discussion that we need.
Is that written down anywhere?
No, it's not working. I think we need to be very honest about that. It is people have their own view about what an integrated service will look like. Quite often, the first thing people will do is to go for organizational integration because they think that's easily achievable. What we've been saying in the long-term transitions and with the achievements like food, etc., is that it's not organizational integration we want. We want integration of working and pathway. From a patient point of view, as Council Gilbert said, they want to see a continuity. They don't care which organization is providing that service. We can't say that we can't achieve that. I think we can achieve all the integration pathway without any additional resources if we can all come to the table and agree to break down some of the barriers. Once that happens, then we can decide where the necessary resources need to go to whichever way it goes. I think that is what that we have got a way to go.
Okay.
No, I was just going to sort of back up what Andy was saying now in terms of, I think we've been having some recent conversations about the challenges that face all organisations, the whole system, and the very fact that we need to come together to understand what that challenge is and how we respond to it. So how do we shape a system for the future that delivers what our community needs in a way that empowers them as well as supporting those who need it, but that frankly costs a lot less than it currently does, because the money will disappear out of the system while we might have a subscription money. There is a real challenge there. So I think Abby has agreed to pull together just an initial conversation and work out what's the right way for us to do that as a cohesive system rather than as individually as organisations trying to work out how do we sort our problem out. Because the days of we could have perhaps maybe persuaded somebody else to help us with our problem are rapidly disappearing in terms of helping out financially.
I think it'd be really helpful if for our next meeting we could actually write down what our vision is of an integrated system for Wirral, because one thing that I've learned over the last few years is that integration means a range of different things depending on who's doing the definition, the defining. So it would be really good if we could have that.
The next formal meeting is in November.
Oh, before that.
Okay.
Before that.
I think with due respect, Chair, I think it is not something that you can just go and write on the back of a back pocket. You need stakeholders. We need to have
in charge of public health.
We need to have all stakeholder engagement in that, and I think there needs to be consultation. And I know that there is it sounds very nice to say we will deliver this for next month, etc. I think we need to sit together and understand the implications and what. And I do believe that there is a lot of work being done. We need to do that together. I think you are driving us towards formalizing it to a document, and I think the pioneer status, etc., will take us as one further step towards it.
No, that's fine. I just like, as the Health and Wellbeing Board, to see a picture of where we're, a destination, what are we trying to... Anna, you want to get...
Just a question from the point of ignorance, so forgive me, but where does the health and wellbeing strategy fit into this? My ignorant understanding would be that articulates a vision for the health and wellbeing board.
Yeah, I'm not, you're right, and we have agreed our cancer strategy, but I'm not sure that document, I mean, I haven't got it in front of me, kind of really sort of, really kind of focuses on the, you know, what would a truly integrated health and social care system would look like. I'm not sure it goes into that kind of detail. And that's the question I'm just asking. And if it's not the Health and Wellbeing Board's job to do that, I don't know whose job it is. Mike.
We're kind of moving on to the next item.
Yeah, sorry, we have.
That's okay.
Would it be presumptuous of me to draw your attention to a bit of the next item?
Right, okay. Should we? Yeah, okay. Andrew,
I wasn't saying we should beat ourselves up about it, because every health and wellbeing is of course having exactly the same discussion. The fact that it maybe have got all the snap of fingers and just point a piece of paper isn't so much of an issue. It is a journey, we are getting there. But all the health and wellbeing reports are starting from different points. Not all the health and wellbeing reports, but there's institutions on there absolutely. So there's different issues that need to be in different areas. So it will be a work in progress. But I think it's a reasonable ask that at some point we have back at this meeting a discussion for us around this table what we need is, what we can capture it, and when these pieces of work will be done.
Okay. Right, can we kind of just park item 6 and sort of note the spending review announcement and then seamlessly go to item 7?
Abby, do you want to start?
Mike? Abby?
I'm the only thing I would say is that, there is a lot of introduction. There has been a long-term conditions code, and the long-term conditions, the whole agenda hasn't put a major impact on how health and social care and is done for the Peninsula and across many other regions. And we identified this as a very, very useful way of doing integration of services together. So prior to even the national move towards pilot status, etc. So we asked the chief execs, asked the empowered long-term conditions to get together a paper to make a bid to the pilot status. And I think we should be mindful that this was done in a very, very quick way because in response to a request that was made on that meets the requirement. We need to, individual organizations, we need to have a proper discussions, and I think we need great input in secondary care and other people, community services, to ensure that this becomes really joined up to support this exercise.
And I was right about all that. Simon was right to talk about whole systems because the long-term conditions integration goal has very much a focus on whole system redesign. If you look at the papers, there's a section headed the vision of the long-term model, where you see it talks of, I've got your page, so that's the page, what page is that? 34.
Okay.
And it talks about shared purpose, it talks about true partnership working, proactivity, and it's in terms of the vision of the future, it's got a list of things there. If you want to see where we think integration will take us, it will be about quality of community care, choice, rapid access, multidisciplinary working, integration of budgets and documentation, the photographs and the assessment. A simple process, let's take the complication out of it for people, helping people find their own solutions. We have the puzzle presentation a while ago, and we saw that's key, we saw that's so important to what we have.